May I please request everyone to settle down? We are going to begin with the event. So it's my privilege to welcome you all today on behalf of the George Institute for Global Health. It's a leading public health institution that started 2 decades ago with a mission to improve the health of millions of people worldwide. Today, the changing environment poses a major threat to the entire planet with very visible impacts on health. The major brunt of these effects is being faced by people in low and middle income countries. While leaders discuss and deliberate solutions for the way forward, we refrain to be passive bystanders. Today, we mark the beginning of a new chapter in our journey with the launch of the NIHR Global Health Research Center for Non-Communicable Diseases and Environmental Change. To know more about the center and our esteemed collaborators, I now invite our Executive Director, Dr. Vivekanand Jha, for the welcome address. Professor Jha is also the chair of the Global Kidney Health Faculty of Medicine, Imperial College London, and the past president of the International Society of Nephrology. He has wide-ranging research interests, including understanding the health and societal impact of kidney diseases around the world and development of affordable, scalable, and sustainable primary and secondary prevention tools. Dr. Jha, please.
Thank you very much, Sarah. And it's so great to see all of you here. First of all, I would join my welcome to that of Sarah on behalf of the George Institute India to the launch event of this National Institute of Health Research, Global Health Research Center on Environment Change and Non-Communicable Diseases. I particularly welcome all our guests from other organizations, those who have come from outside Delhi to be with us this morning and join us in this launch. We have a number of colleagues also joining us online from different parts of India and indeed from other countries as well, and I welcome you all. We are indeed meeting at a very important turn in human history. This week, we reached a symbolic milestone of 8 billion people on this earth, which means that a large number of people actually are surviving childhood and reaching adulthood. And there we all know that they run the risk of developing non-communicable diseases. There are a number of drivers of non-communicable diseases, one of which now we know very well is climate change. And with regard to climate change also, we are currently in the middle of the United Nations Climate Change Conference, also called the COP27. It's happening this week. It's entered the second week, and vigorous discussions and negotiations are going on at Sharm el-Sheikh. The main message that is emerging from the researchers who are participating in and following the COP27 proceedings is that we need action, not just words. Both these non-communicable diseases and climate change have been identified as the most important threats to human health, which makes the work of this center, about which you are going to hear more during the course of the day, even more important than usual. In this mission, we are joined by like-minded institutions, and I'm really pleased to welcome all our partner institutions and colleagues from there: Imperial College London, ICTDRB Dhaka in Bangladesh, Brawijaya University Malang in Indonesia, and Sri Ramchandra Institute of Higher Education and Research, Chennai in India. We are really very pleased that you have been able to join us for this event, and the series of discussion meetings which are taking place around this event. We had a series of events yesterday, and there will be more tomorrow as well. I'm particularly grateful to our keynote speaker who will join us shortly, Mr. C.K. Mishra, who has had the unique position of having shaped policy responses for the Government of India at the apex of the two ministries of Health and Environment Ministry as well. My warm welcome also to all the experts who will share their thoughts during the panel discussion part of today, and the young investigators and researchers who will present their work this afternoon. None of this would have been possible without us securing the support of the NIHR in the UK, and I welcome colleagues from NIHR also who are with us. They shared their thoughts about how this program needs to be run, and they will be working with us throughout the course of the center. Last but not the least, my warm welcome to all colleagues from our other offices of the George Institute. The George Institute is indeed a global institution, and without the involvement of all our colleagues from other offices, this proposal would not have come together so nicely as it did and was successful in actually securing this grant. Therefore, my dear friends, while today will be all about words, as the message is coming out of the COP27, we will transition to action straight away after today, and hope that we will be able to report back to you on a regular basis on the progress that we make and keep you apprised and really learn from you, because community engagement and capacity building is also going to be a really key feature of this Non-Communicable Disease and Environment Change Research Center. So with those words, I once again add my welcome to those of my colleagues at the George Institute, and we'll proceed on with the deliberations of the day. So back to you, Sarah.
We will indeed transition to action. And on that note, it's time to formally launch the center. I would like to hand over now to Dr. Praveen for this segment. Praveen is a Senior Research Fellow and the head of the Primary Healthcare Research at the George Institute, India. Praveen will also be the director of the new center. So over to Praveen.
Good morning, everyone, and welcome again to this August presence and to the launch of the center. So first, we will start with the diya lighting and the cultural significance of the lighting for our collaborators and guests from outside India. Light is a symbol of prosperity, well-being, and abundance. Light also represents knowledge in India. Lighting the ceremonial lamp signifies a new step in the direction of knowledge, truth, and prosperity. Today, in sync with the culture of the land, I invite Dr. Vivek Jha, please. Chris, please. Dr. Alia, Dr. Vidya, Dr. Andrini. Yeah, we can stand there near the diya, and then we can, yeah.
Climate information.
Great. With that lighting ceremony, and we now start the process. I will invite Dr. Chris Millett. He is from the Imperial College London, and he's the co-PI of this grant, the NIHR grant, and he will talk to us about the food systems in India, which in India, Indonesia, and Bangladesh, which we'll be working on. Yeah, sorry, just to give an overview of the center and what we will be working on, we have a small video that has been developed by the comms team. and we will be playing the video, and then we will have our talks. Sorry, Chris. Abhishek, over to you.
Our planet's health is our health. We're all interconnected. The air we breathe, the water we drink, and soil we harvest. The climate crisis is a health crisis, and no one is safe. The World Health Organization calls climate change the single biggest health threat facing humanity.
Low and middle-income countries are especially at risk of climate change-induced disasters. Due to weak infrastructure and poor access to high-quality primary healthcare, LMICs face the dual challenges of the growing non-communicable diseases and global environmental change. Despite increased recognition of a need for action, there is limited evidence on cost-effective, sustainable, and community-integrated interventions and inadequate research capacity to address these challenges. The NIHR Global Health Research Center for Non-Communicable Diseases and Environmental Change, a partnership between Imperial College London and the George Institute for Global Health India, will work to tackle the dual challenges of a rapidly growing burden on non-communicable diseases and the threat of global environmental change in Bangladesh, Indonesia, and India to foster health equity, well-being, and environmental sustainability through multi-sectoral interventions. In Bangladesh, storm surges caused by tropical cyclones have led to an increase in water salinity across the coastal belt. This has harmful health effects on local population, including increased blood pressure, progressive kidney disease, and gestational hypertension in pregnant women.
আমাদের এই দক্ষিণ অঞ্চলটা সম্পূর্ণ লবণাক্ত পানিতে ভরা, কারণ আমাদের এখানে টিউবওয়েল আছে, দেখেন এই পানিটা সম্পূর্ণ লবণাক্ত পানি, এটা আমরা খাওয়ার কোনো উপযোগী নয়।
আমার হার্টের অসুখ এনতে বোধহয় আপনার 3-4 বছর আগে, তারপর আমি ওই জানিনি তো জানতে পারিনি, তারপর ডাক্তারের এখানে গেলাম।
Despite several solutions that are brought in the coastal areas, people are still drinking high concentration salt water in their daily living.
The center will work with the International Center for Diarrheal Disease Research Bangladesh to identify and test cost-effective, sustainable solutions to reduce salinity in water supply in the districts of Khulna and Satkhira. The unregulated burning of plastic waste in Indonesia releases harmful chemicals such as dioxins, which pollute the environment and lead to negative health outcomes such as chronic lung and heart diseases and cancers.
Indonesia menjadi negara tertinggi kelima kandungan dioksin dalam telur ayam, 80 kali lipat dari standar yang dianjurkan oleh WHO.
Almost half of Indonesian plastic waste, about 48%, is openly burned, especially in rural areas. Despite this, the potential human health effect of plastic burning in this country remain under study.
Along with the University of Brawijaya, Indonesia, researchers will test a range of multi-sectoral interventions to reduce exposure to air pollutants caused by the burning of plastic waste in Malang district in East Java. In India, deteriorating dietary diversity conditions and malnutrition are among the leading cause of rapid growth of non-communicable diseases such as diabetes and cardiovascular diseases. The public food procurement system provides supplementary nutrition to millions of individuals. States have experimented with several interventions like diversifying the public distribution system, launching the millet mission in states, introducing nutrition gardens as part of supplementary feeding programs and others.
The Centre will systematically document and analyze public food procurement policies and identify environment-friendly interventions across the food supply chain. The idea is to diversify the food basket by co-designing an environmentally sustainable food systems intervention in discussion with the community and the policymakers, and an intervention which will lead to NCD risk reduction.
The NIHR Global Health Research Center for Non-Communicable Diseases and Environmental Change will engage patients, communities, including indigenous communities, and work to strengthen and support healthcare systems through a digital platform which will capture community environmental risks, behavioral risk factors, and disease management from the 3 countries. The center will also identify opportunities for strengthening impact outcomes, community engagement and involvement activities. The NIHR Global Health Research Center for NCDs and environmental change will benefit the most vulnerable and go a long way to contributing to improving planetary health.
Thanks all. With this background of the NIHR Center, can I request Chris Millett second time to come here and speak, please?
Excellent. That was a terrific video, so thank you for everyone that put that together, and it really illustrates the scale of the challenge we face and the importance every day of waking up and feeling energized to make progress in this important challenge. So I think the plan now is for each of the co-investigators to present a little bit more context on some of the interventions we're thinking about. But first of all, introduce myself. So Christopher Millett, Professor of Public Health at Imperial College, co-leading the centre. Enormous privilege to be assuming this role. The planning for the centre, the application was 2 years in the making. So an enormous amount of effort across all the teams to get to this stage. So talk a little bit more about the challenge of food systems. And as you would have seen from the video, this fits into this what we sort of is the WHO comprehensive model of primary healthcare, where we not only think about how the health system can respond to the changing disease burden associated with environmental exposure, but really trying to change those exposures through multi-sectoral interventions and doing so with communities. So that's really the essence of the centre's mission. So food systems and health. We know that our food systems at present globally aren't very healthy. They're not conducive to good health because too many people are not getting enough food, and too many people are also eating too much, particularly increasingly ultra-processed foods. And so if you look at the indicators here, you can see both on the undernutrition side and the overnutrition side, the trends are not good. And our particular focus obviously is around the chronic diseases, so the fact that overconsumption and other risk factors in dietary systems and elsewhere is increasing diabetes, heart disease, and cancers. But as we've realised in discussions over the last few weeks, that some of the interventions will have tremendous potential benefit for undernutrition as well. So food systems aren't necessarily healthy for the environment as well. So they contribute 30% to greenhouse gas emissions, more than 70% of fresh water use, and the largest cause of species biodiversity loss. And the trajectory in terms of looking forward isn't optimistic, one of optimism, with increasing consumption of those products which we know are environmentally harmful, including red meat. So I want you to look at this picture and imagine a future in which in India we have a different scenario moving forward. So I think this market is beautifully illustrative of a bright future ahead that could be realised in India. We've got a diet which is predominantly focused on fruit and vegetables, lots of different colours, lots of nutrients in that. And this is the sort of transition that we actually need and we're hoping to contribute to in India. I think there's other interesting elements. Unlike the PM 2.5 levels today in New Delhi, we have a very clear sky. And this is because if we transition towards more fruit and vegetables and have less in the way of cereals, basic cereals like rice, we have less opportunities or necessity to burn crops and produce smoke, which ultimately produces air pollution, which is harmful for health. So the intersection between agriculture and air pollution is also important, and we wish to study. And we can see a woman there, and she's actually sitting down, she's smiling, she's conversing, and she's doing so because she's feeling economically secure. And this is because what we envisage is not only direct health benefits, but indirect health benefits flowing from a changed food system, which provides economic security to women and other groups such that they get a fair price when they grow and sell their produce. So this is a future, and also the temperature on this day is about 27 degrees, and actually we're seeing fewer heat waves and fewer floods than we wouldn't have otherwise anticipated, because the trajectory in terms of food systems means that we're actually negating future risks of these catastrophic climate events, which also are important in terms of the centre's focus. So you can see that food system interventions are quite important in terms of that global impact of climate change on health. We've got a distance to achieve that ambition. We know that there's an over-dependence within the Indian diet on basic crops, rice and wheat. So 2/3 of calories consumed amongst people in rural India are from those crops. We have underconsumption of fruit and vegetables and nuts. And we're creeping up in terms of fats and edible oils, particularly in urban areas, which probably represents increasing ultra-processed food consumption. So we think that actually food aid, not only in India, but in partner countries and globally, is a really important mechanism to shift the needle in terms of agricultural systems and food systems. And this is a document by the WHO recommending exactly that coverage should better leverage public procurement for health objectives, but also for sustainability. And this is the final slide briefly. As mentioned in the video, we aim to experiment with food baskets in the PDS to consider introducing pulses, to, where possible, introduce fruit and vegetables, to remove some of the harmful products in those baskets as well, such that they help us transition to that bright picture of a future of India which has healthier indicators, nutrition indicators, healthier environmental indicators, and ultimately a sustainable and healthy food system. So I'll leave it there, and thank you.
Thanks, Chris. That was a useful glimpse of the food systems, and the plan is we will talk of the 4 multi-sectoral interventions that we'll be working on, and then followed by me, who will try to club all of those things and show you the big picture. I now invite Dr. Vidya Venugopal. She is the Professor of Occupational and Environmental Health at the Department of Environmental Health Engineering, Sri Ramachandra Institute of Higher Education and Research, India.
A very good morning to all of you. It's my privilege to talk to this august presence. The picture in the opening slide does look grim, and the truth is it is grim. It's going to get much grimmer. And I, on behalf of my team, India Heat Team, present the facts why heat stress is an important issue, especially when the climate is changing and the rising temperatures are going to I don't want to use the word havoc, but it's going to make changes that are not reversible unless we make adaptations right now. Rising temperatures is an alarming issue. COP27 is speaking, where people in WHO are speaking, ILO is speaking, everybody is speaking about it. And there are multiple agencies that say climate is changing and heat is going to be a very important issue because it is touching every single person who lives. India has also had a lot of economic implications because of heat. And it's lost about 5.4% of its GDP to extreme heat in just 2021, right? And deaths are happening, mortality is happening, morbidities are happening. We have very less data on morbidity data from India. Very few research groups are generating data on morbidity data right now, but you can very clearly see that over 7 lakh deaths in India per year due to abnormal temperatures. So this is what we see right now. And it's happening, like hot days are increasing. We just had about 280 days of heat waves across 16 states in just 2022, and it's likely to increase more. When we are speaking about heat, it's just not the heat, the ambient temperatures. Wet bulb globe temperature, which is the heat, the ambient temperature plus the humidity that actually drives what happens to the health of a person. And on the left side, you see the number of heat days in 2050, which is not very far away, just about 30 years from now. It's going to increase, and the wet bulb globe temperature is going to be like quite high. In certain parts of India, it's going to be very, very hard for people to even live inside homes, forget about working outside. And when the WBGT, which is a wet bulb globe temperature, that is an index for heat stress, increases, morbidity and mortality is expected to increase significantly high. And it's just not about heat stress. We have heat-related illnesses, that's one thing. But what happens is when it comes to NCDs, you're also going to have people who are exposed to heat and dehydration, have a lot of kidney disease across the globe we are going to have. And our own studies say that people who are working indoors are going to have or having kidney diseases. 9% of people whom we worked with in steel industries had kidney stones. It's been also linked to HRIs and kidney diseases. Who is most vulnerable? Apart from the community members, like the older people, the children, and the ones who are working outdoors are the most vulnerable to heat because they are exposed to heat outside. They are exposed to the humidity, plus also when you say heat stress is just not about the temporary environmental factors. It's about the metabolic workload that a person exerts. Okay, those three together form the WBGT index. So we have about 673 million workers who are working outdoors, and 93% of them are informal sectors who do not have any insurance. They are just like left to defend themselves when they have any occupational health issue, including an HRI. And 600 million workers employed in India are exposed to high heat conditions for most part of the year. 6 to 8 months in a year, they are exposed to high heat stress. This is from ILO. But we also have to question certain myths that are existing. One is indoor occupations are safer because they are like have a roof over them. That's like it's a big myth. And the thing about heat is just common in India because we have always been a hot country, tropical country, so heat is safe, it's fine, it's normal, and then body can endlessly adapt to it. That's again a big myth because we are already seeing the negative effects of heat stress on working people and the communities as well. So what really happens is like when there is when a person is exposed to heat stress, whether it's a community person or a vulnerable group, what happens is there is a rise in core body temperature, your urine specific gravity goes high, excessive sweating, thirst, that could lead to chronic dehydration and repetitive kidney injury that kind of precipitates to chronic kidney diseases. So this is something that we have seen in our own studies. The salt pan workers, about 51% of the salt pan workers that we have worked who are exposed to high heat, humidity, and heavy workload, about 51% of them have eGFR, which is an indicator of your kidney function, less than 90. And then stage 3A, which is like less than 60, about 7% of them are there. This is just in a short, small group that we worked with, about 500 workers. And in the informal sectors in Andhra Pradesh, where we worked with lots of different varieties of occupation, 76% of them have lower kidney function. That's just a starting. And then stage 3A, 17% means they are already into an CKD stage. And our Tamil Nadu government insurance data says the kidney dialysis needs are increasing 7.2-fold per year. So more and more people are getting exposed to heat. It's probably not just to heat, but this is just kind of an indication. And we have seen that heat has a significant association with incidence of HRIs and renal illnesses. So what do? Need of the hour is the urgent, effective, low-cost, feasible, sustainable heat mitigation strategies. That's what it is needed. And we have to intervene at the community level. We have to intervene at the vulnerable group level, right? And we have to first understand the needs of the community, what is already available, and what kind of interventions would work, and what kind of implemented methods have been done elsewhere, because in Central America, in few other countries, there have been heat action plans for the community and for the vulnerable group that has happened. And how effective are they going to eat? How are we going to measure it? Whether has it really worked for these workers? Has it really worked for the communities is something that we need to do. So we have a broad framework as to what we want to do with this, and we, do something that can be scaled to other communities too. If we don't do anything, we are going to have like India's 40% of our economy is going to be still dependent on manual labor and heat exposures. Means we are going to be 40% of the worker community is going to be working still manually, because automation is something that we still need to go further, and increase in lost labor hours. People won't be able to work outside or even inside for that matter. And then we are going to be losing about like $150 to $250 billion, right? And this is from the Climate Vulnerability Monitor. Nobody has ever questioned that monitor, the sustainability report that was given. And it's equivalent to about losing 800 million jobs. So it's quite high. And the burden of health system is also going to increase. Like I said, we already need more dialysis units and everything. And the future generation would be a poor health workforce. So thank you very much. Yeah.
Thanks, Dr. Vidya. So now, can I invite Dr. Alia Nahid? She is the scientist and head Initiative for Non-Communicable Diseases, Health Systems and Population Studies, ICDDRB from Bangladesh. Thanks for being here.
Thank you, Vivek. My colleagues on the podium, dignitaries in the audience. I don't know whether you are appreciating, this is a great day. Probably Vidya created the stage for me to tell you what Bangladesh is trying to do and why. You all know Bangladesh is the most affected by climate change vulnerability, and it is the top-ranked country by the index that has been released in the 6th annual report. This country is also geographically located in a position that it is in the second largest river basin. Storm surge and natural disaster is so common, and saltwater intrusion is such a common thing that gradually our freshwater resources are being replaced by water with high salinity, like salt is being mixed with everyday water that people need to drink or cook food or use it for other purposes. Yes, these are the impact of climate change. Rise of the heat is causing rise of the sea level, and all these natural disasters are also causing salt intrusion in freshwater resources. The land is the habitat of more than 170 million people, and 34 million people live in the coastal areas who drink salt water on an everyday basis. They have very little opportunity to look for an alternative unless some charity organization or the government is trying to build some local solution, some technology in place. Otherwise, what do? They drink from rainwater, they harvest it, they store it for the whole year. And when it dries up during the hot season or during winter, they look for alternative solution. So what is the solution for them? Go back to those tube wells, they're still full of salt in water. Environmental scientists have been trying to look for solutions for several years. But sadly, they never thought of what technology they should think of that would also bring positive impact on health of people. They were totally unaware of the impact of health and what should be done. And on the other hand, the health scientists, researchers, providers, they are trying to protect health, they're trying to do something that will improve their health condition, but they have no understanding how we can work together with the environmental scientists to mitigate the environmental risk to reduce the impact, negative impact on health. It is a very good day for us because the NIHR Global Health Research Center for Environment Change and NCDs allowed us for the first time that we put together environmental scientists and the health scientists together to come up with a solution. What is the solution? That is the question. There are solutions in the community. There are practices in the community that we call citizen science. People try to look for solutions, but we don't know the robustness or the verification of the goodness of the solutions. So our scientists are putting together some technology innovation of drinking water, how this can be, groundwater can be made less salty and safer for drinking and use of other purposes. Drinking water, high salinated drinking water particularly, is causing a lot of health hazard. When we are told it's hypertension, and which is very high in Bangladesh, and particularly in the coastal areas, and myocardial infarction, stroke, they are very common, and particularly it happens in younger people in Bangladesh. People are younger in Bangladesh than people living in Pakistan and India who have their first incidence of myocardial infarction. But there is so little solution because health systems is so fragile. And the coastal areas, there is basically no support. So basically people look at their fate and accept it. There are communities where a mother have not met a qualified medical doctor in her entire life until we went to visit her. So this is such a grave situation in the coastal areas in Bangladesh. So what we want to develop a comprehensive health systems improvement so that people get their basic health care and at the same time they can get interventions for mitigating the risks of non-communicable diseases. And this is a great time to combine with environmental technology so that people can get safer desalinized water for their everyday living. So I'm not going to talk about the science here today, but what I want to tell that water salinity, coastal area, and fragile health system with limited access to care, this is not the only problem in Bangladesh. Heat is an issue, huge issue. Food system is a huge issue. Air pollution is a huge issue. But how can we solve all of them? We can't. This is why our 3 centers have decided to focus on individual aspects of heat, air pollution, and food systems, and Bangladesh is concentrating, finding solutions for innovation, for a technology that will reduce water salinity and also improve health of people in Bangladesh. So we need to learn from each other, and it is a very challenging journey for all of us, but this is very ambitious, but also promising, not only for Bangladesh, but also from all the South Asian countries who are located in the Delta region, and maybe for other countries in the world who are at the risk of climate change vulnerability. So I would summon everyone support the NIHR Global Health Research Center for NCD Environmental Change by all means, and we look forward to a success in the next few years. Thank you very much.
Thanks, Rotalia. So now, can I invite Dr. Sri Andrini? She is the Professor of Medicine, Department of Public Health, University of Brawijaya from Indonesia.
Bismillahirrahmanirrahim. Good morning, everybody. I would like, first of all, to thank the organizer of this meeting, of this wonderful launching meeting of our research center. On behalf of the Indonesian team, I would like to say thank you again for the opportunity for Brawijaya University to work together in the research center. Indonesian plastic waste is estimated to be 4.8 million tons annually, with almost half, 48%, openly burned. The plastic burning from both industry and community activity result in poor air quality in East Java areas. Based on Ministry of Environment and Forestry report, in 2020, air quality in this area has exceeded WHO guideline value for safety, with the PM 2.5 concentration. Sorry. Okay. Next slide. Okay, sorry. Yeah. Okay. Thanks. Similarly, the second highest level of dioxin ever measured in eggs from Asia was found in samples collected near a tofu factory in Tropodo, Mojokerto, East Java, that burn plastic waste for fuel. Plastic pollution is therefore a prominent aspect of environmental change in low middle-income country, with its ungraduate burning presenting in a substance source of PM 2.5 and anthropogenic chemical species such as dioxin and platelet in the ambient environment. There is no ample evidence that the elevated exposure to this pollutant can lead to the onset, the worsening of the range and NCD, including chronic obstructive pulmonary diseases, cardiovascular diseases, and cancer. As plastic production is predicted to increase globally to an accumulated 25 million by 2050, mitigation for environmental impact of plastic burning has an increasingly important role to play in the public health response to NCD prevention and management. At the same time, NCD, especially cardiovascular diseases, become the biggest burden of Indonesian health system. Stroke, ischemic heart disease, and diabetes become the major cause of death in the country. Metabolic risk are high risk factor of death and disability, while air pollution in the top 10 risk factor that drive the most death and disability in the country. As can be seen from this map, air pollution contributes to 6 to 10% daily in our study area, which is quite familiar what happened in India and Bangladesh. The NIHR Center will be extremely important to support institutions and Indonesians together solving the issues. In the short term, the center has strategy roles to build capacity of researchers in the university and community, so that we can find solutions to tackle risks of environment change and burden of NCDs. The center has also had the strategy roles to provide policies advice to local and national government especially to protect and help the most vulnerable people in the high polluted area. In the long term, the center has strategic role to build strong and sustainable healthcare system to mitigate risk of environmental change. This is a very vital for reducing the premature death and disability, and thus achieving health for all and healthy society. Lastly, I want to say this quote: collaboration and teamwork give us the best opportunity to turn vision into reality. I believe that teamwork and collaboration of all of us, we can turn our center vision into reality. Thank you.
Thanks, Dr. Andrini. Yeah, with this background of different multi-sectoral interventions that we will be conducting in Indonesia, in Bangladesh, in India, let me just try to bring all of this together here. So this is our NIHR Center for NCDs and Environmental Change. And as you can see, it provides the overview of the center. The aim of the center is to become a recognized center for excellence on NCDs and global environmental change in LMICs within the next 5 years. Co-producing world-leading implementation research with local communities, strengthening the research capabilities, advocating, and policy for health equity. The center will have 3 research themes, which is centering on implementation of all the 3 PHC components which are based on WHO's comprehensive primary healthcare model. The theme 1, which is on the circle on the lower part, the theme 1 focuses on strengthening the primary healthcare and essential public health services for NCD prevention and management in communities affected by rapid environmental change. And theme 1 will be in all the 3 countries, and the theme 1 will be in close, it will work very closely with the multisectoral actions and interventions that we are planning for each of this country. The theme 2 focuses on developing and evaluating the multisectoral interventions that have dual benefits in reducing the burden of NCDs and hazardous environmental exposures at the population level. And we have heard from our members the different multisectoral interventions that will be focusing in all the 3 countries. In theme 3, we will focus on evidence-based action for empowering communities and individuals to be actively involved in research, advocacy, and policy. Encompassing all of these themes would be the research capacity strengthening, which we understand is very new. I mean, these topics are very new, and we will definitely want to work along this to strengthen the research capacity at the individual level, at the institutional level, network and ecosystems level, in order to enable LMIC-led production and use of high-quality evidence. Theme 1 is again strengthening the primary healthcare to address environmental hazards, and here we will be using a digital health platform to implement both the health-related interventions as well as to support the implementation of the multisectoral intervention. In theme 1, we will be expanding the digital health platform that we already have, which we called as the Systematic Medical Appraisal, Referral and Treatment, in short, the Smart Health Platform, to establish a common data platform to comprehensively capture community environmental risks, behavioral risk factors, and disease management. We will expand the existing primary healthcare strengthening strategies and conduct a large-scale implementation and evaluation of the comprehensive primary healthcare strategy targeting people with high risks of NCDs, which is cardiovascular disease, type 2 diabetes mellitus, chronic kidney diseases, and chronic obstructive pulmonary diseases. In Bangladesh, we will be using a parallel platform which is already in use and which is called as the COBRA BPS platform, and we will try to work with the existing systems we already have. This is the multisectoral interventions, and as we have already gone through, in India we will be focusing on food systems, and we will also work on heat stress that Dr. Vidya has presented. In Bangladesh, we will be working on water desalination, and in Indonesia we will be working on air pollution with a focus on plastic burning. And this is theme 3. This shows we'll be focusing on empowering the people and the communities. We'll be conducting a policy review in order to understand the nature of community engagement and initiatives in all these 3 countries. And then we will be developing our focus areas in all of these 3 individual countries. We will conduct a detailed process evaluation, integrate the community engagement and initiative within all the 2 different themes, Theme 1 and Theme 2, and understand how well the CEI activities have been implemented under all these themes. And we will be utilizing the overall findings from these themes to prospectively plan for how to best drive future community engagement initiatives in research, advocacy, and policy. So this is an example of how complex this entire program is, and with the community engagement initiative, which is the integral part of the entire program for us. So here is an example of the work from India, where we can see the Theme 1, which is focused on primary healthcare through the Smart Health platform. We have Theme 2, which is mostly based on food systems, interventions, and also mitigating heat stress in the communities. And then we have Theme 3, which is empowering the people and using the community engagement initiative integrately within Theme 1 and Theme 2. So the center, for theme, the center will be based at the TGI India and will take a network approach with distributed global leadership of working groups to maximize the cross-fertilization, efficiency gains, and quality assurance between 160 collaborators across India, Indonesia, Bangladesh, and the UK. The interventions will be co-developed for the first 2 years, and then it will be implemented for the next 2 years, and then we will be evaluating this through a quasi-experimental difference in difference design to assess the outcomes in the intervention and the control regions in each country. Communities for intervention will be selected where the resources could be more easily deployed in a timely fashion. Matched controls will be selected based on population size, rurality, and socioeconomic status. So consistent with the MRC guidance, we will assess the effects on multiple outcomes. So with this starts a new journey of 4 different countries, a complex intervention looking at environmental change and NCDs. And this leads us to the end of this session, and I will now hand over my mic to the next speaker. And thank you very much, all collaborators and co-investigators for this grant.
Thank you, Chris, Praveen, Aliyah, Vidya, and Sri. We now continue our proceedings with the keynote address. Our keynote speaker for the day, Mr. C.K. Mishra, has served as an administrator, policymaker, and public health strategist, holding a wide range of assignments in the field of health, education, environment, industry, and power. Starting in 1983, Mr. Mishra has held various positions in the Indian Administrative Service and served the people of India for over 40 years. He rose to the position of the Secretary of the Ministry of Health and Family Welfare, as well as the Ministry of Environment, Forest and Climate Change of the Government of India. This combination makes him uniquely positioned to provide reflections on the topic that our center is all about, which is the intersection of environment and health. Before taking on these roles as the additional secretary in the Department of Health, he was the mission director of the National Health Mission, which is the largest public health program anywhere in the world. He also held additional charges of the ministries of Ayush, which is the indigenous knowledge in the health systems that we have in India. And when COVID broke, he headed the empowered group on availability of hospitals, isolation and quarantine facilities, disease surveillance and testing, and supervised the clinical training formed under the Disaster Management Act for COVID-19 management. Mr. Mishra is recognized for his significant contributions for improving the Indian public health landscape. After retiring from the Government of India, he took on his current role at the IPE Global, where he continues to support equitable development and sustainable growth in developing countries. May I now invite Mr. Mishra for the keynote address, which is entitled Empowering Health in a Changing Environment, Time for Action. Mr. Mishra, please.
A very good morning, everybody. And thank you, Vivekanand, for that longish introduction. I am not very sure whether each of what you said is correct, but we'll live with that and I'll feel happy about it. When Vivekanand approached me the other day to come and participate in this and speak, what really attracted me is that the two of the biggest challenges that not just India but globe is facing, climate change and environment and the rise of NCDs, are being put together in a basket. Many have done it before, but what is more attractive about this is there'll be some on-ground research to find out where it stands, what it means, and what really needs to be done. As he read out, I was asked to speak on empowering. And, we really are looking at a situation. And we need to reflect very seriously, not at the empowering bit, but think about the 2 years when you were totally powerless. And the last 2 years, when scientists, clinicians, general people felt totally powerless, brought to us a story that we need to weave together for the future, where we need to create a coping mechanism which saves human lives. See, yesterday at the COP27 there was a discussion happening on the intersection of health and climate, as you mentioned. Very eminent scientists, known names were speaking. And honestly speaking, I understood just about a little bit of what was being said. And I'm pretty sure that anybody in the Mufassil areas or a rural village or a tier 3 city would have understood nothing. Because the language that we use to communicate the problems of health and environment is absolutely non-understandable. So the first and foremost requirement when we are talking about empowering the system is to demystify the dangers of health and environment. People get scared. They should be, actually. Unfortunately, they're not getting scared by the ground reality. They're getting scared by the words you use. We need to really get on to a simple language by which they start seeing the ground reality. At least I'll make an effort today as I speak for a little while after this to keep things as simple as possible. So we are assembled here after a very difficult COVID period of the last 2 years that I was referring to, where the most powerful, efficient, and extremely well-resourced health systems in the world collapsed. It's a miracle that some of the very badly funded, very badly kept health systems survived. But what COVID taught us is that creation of a healthcare platform is something that does not have a finality. You need to continuously keep working on it. And that is one lesson the globe has learnt, and one lesson many countries are forgetting very soon. And that is the danger. The lessons learnt must be carried forward and implemented. So what really we are looking at is creating a resilient health system. And in simple terms, what do you mean by a resilient health system? A resilient health system, according to me, is a system that delivers, is a system that withstands, and a system that is able to cope. And I would not like to get into any technical issues beyond this, because that is what the people need. Health systems, I always say it's not about health system, it's about healthcare delivery. A system, no matter how robust it is, if it cannot deliver, it's not worth it. And healthcare delivery system, unfortunately, is not equal to the strength of your healthcare system. There's something in between the infrastructure that you create and the delivery mechanism that you have, which actually makes the difference. And that is the difference which I think